A highly trained physician can memorize every textbook and ace every board exam, but still miss a basic diagnosis. These failures rarely stem from a lack of medical knowledge. Instead, they are the result of biological trade-offs. Evolution has optimized the human brain for rapid survival decisions rather than the slow, analytical demands of a modern hospital. As a physician on a busy shift, you are bombarded with a massive volume of ambiguous patient data. To survive this cognitive workload without freezing up, your brain relies on heuristics, essential mental shortcuts that help you process information quickly. Under the stress of an emergency, these essential tools misfire, becoming cognitive biases, the primary cause of diagnostic error. These shortcuts guarantee diagnostic speed, but they simultaneously create cognitive blind spots that can lead to lethal mistakes. You cannot eliminate heuristics. It is biologically impossible. The goal is to identify exactly when you need to safely override them. Mitigating cognitive biases doesn't mean simply trying to pay closer attention. It requires you to strategically inject friction into your automated thinking to prevent catastrophic errors. This chart shows the central trade-off. As a shift progresses, diagnostic speed and confidence rise sharply to handle patient volume, while accuracy steadily declines. Their intersection creates the danger zone. Here, reliance on mental autopilot peaks and careful data evaluation bottoms out. To disrupt this automated process, you need what we call cognitive friction, a deliberate, forced pause. The barrier is that creating this friction costs precious time and mental energy exactly when you have the least to spare. But paying that small upfront cost is the only reliable way to avoid the massive downstream systemic costs and patient harm of a severe misdiagnosis. To evaluate which biases to target, map them on this quadrant chart, weighing the cognitive effort required against the impact on diagnostic safety. 3 specific biases land in the top left quadrant. Anchoring, availability, and confirmation are your highest return on investment targets. Anchoring bias locks you onto the first piece of information you receive. If EMS dispatches a patient as a stroke, it is incredibly easy to interpret every symptom through that lens, even when the exam clearly points to hypoglycemia. This chart tracks anchoring bias, involved in 60% of diagnostic errors. Once the brain locks on to that first piece of information, it stops adjusting. If a patient with a pulled muscle develops a fever, the doctor stays anchored, missing a spinal abscess. The mitigation for anchoring is simple. Force yourself to ask, what else could this be? At least twice per patient. Availability bias happens when recent, dramatic cases artificially inflate your perception of a disease's current probability. And confirmation bias pushes you to interpret new data in ways that fit your initial guess, like downplaying a normal chest X-ray just to force a patient's symptoms into a diagnosis of pneumonia. In these moments, the workup stops being an objective investigation and becomes a psychological effort to prove the doctor was right the first time. Mastering these 3 biases yields the highest return because the mitigations take mere seconds, but they prevent the most common diagnostic failures. Beyond your internal shortcuts, you also have to manage systemic biases generated by the hospital environment itself. Diagnostic momentum occurs when a label gains inertia. An initial guess passes from triage to the attending, hardening into unquestioned fact along the way. This creates a framing effect. If subjective language from triage labels someone a drug seeker, it corrupts your objective evaluation of their actual physical pain. To defeat these, you must deliberately seek out raw primary data, vitals and lab results, before you read any previous chart notes. Breaking diagnostic momentum requires an uncomfortable trade-off. You have to trust raw data over the assumed competence of previous clinicians in the hierarchy. Another set of traps, affective, ascertainment, and fundamental attribution biases, are triggered by a patient's demographic or your own emotional state. Affective bias then layers onto this initial frame. An emotional reaction to an abrasive or difficult patient can lead a physician to shorten a physical exam, potentially dismissing a serious condition like appendicitis as minor indigestion. The largest slice of this error chart is premature closure, which accounts for 58.5% of cognitive mistakes. This occurs when the search for a diagnosis ends the moment a single plausible answer is found. A doctor finds a fracture in the ankle, stops looking, and completely misses a secondary injury in the same patient's knee. Stereotyping or simple frustration can cause you to bypass standard workups. It is easy to label a confused, difficult patient as non-compliant, rather than recognizing the underlying delirium. The solution is to deploy rigid, standardized clinical protocols for high-risk presentations like sepsis, regardless of how the patient presents. The trade-off is that using rigid protocols feels impersonal, robotic, and directly challenges your belief in your own clinical intuition. But removing intuition from high-risk scenarios is a necessary safeguard to protect the patient from your subjective emotional state. Highly experienced physicians face premature closure and overconfidence. These are ego traps that catch doctors who rely heavily on pattern recognition. This leads to good enough thinking. You accept a simple diagnosis, like a viral illness, while ignoring subtle, contradictory symptoms. The prescription for this is a forced diagnostic timeout. Ask yourself specifically, What finding does my current diagnosis absolutely not explain? Admitting personal fallibility and actively hunting for evidence that proves yourself wrong is the ultimate safeguard against ego-driven blind spots. This flowchart provides a definitive step-by-step algorithm designed to force cognitive friction during every new patient encounter. You start at the first major decision gate. Does a pre-existing label exist? If so, strip it away and review the raw data first. Then you reach the second major decision gate. You actively check for missing or contradictory symptoms that don't fit your working theory. Based on that check, you determine whether to proceed with treatment or if you need to completely reset the baseline diagnosis. Relying on willpower to remember biases will fail. True mitigation requires adopting a forced function system that dictates exactly when to pause. If you are a junior resident or intern, prioritize fighting diagnostic momentum, rely on checklists, and actively ignore triage labels. If you are a senior attending, recognize that world-class pattern recognition increases your vulnerability to overconfidence. Prioritize hunting for disconfirming data. For everyone, the central trade-off remains. Safety requires a conscious sacrifice of speed. Cognitive bias is a permanent biological reality. It is not a character flaw to be cured. True clinical mastery is not the absence of bias, but the continuous, deliberate application of systemic reflection to protect patient outcomes. To keep these biases top of mind during a shift, clinicians use a mnemonic. All anchors and confirmations delay finding optimal progress. This tool maps the biases to the patient's journey, from the first impression at the door to the final decision at discharge. Reducing diagnostic error requires the active, continuous practice of questioning one's own clinical path. Medical expertise is maintained through this constant state of intellectual humility.
Si scostino e tratto se stendi